So thank you, Edson, for a whirlwind tour, incredibly informative view of sort of what we needed to understand on both sides of the supply and demand and the market in between. So we're going to take a couple minutes for a couple questions from Edson, and then we're going to switch gears into taking the amazing wealth of information that Edson provided us with and sort of synthesize it into a model that will become for this committee sort of the dynamic touch point of the next couple days in terms of how we think about supply on one side, demand on the other, the market in between, and what we can be doing to redesign health professions, education, financing. So a couple questions for Edson. Back here.
I had a question on each side of the model. I had a question on the supply side. I noticed one of your graphs differentiated millennial hours, and I wondered if you could talk a little bit more about that. And then on the demand side, I wondered if you could speak to the issue of discrepancy between need and perceived demand, in particular, more in regards to consumer choice about whether or not individuals follow recommendations and guidelines for preventive care or frequency of care as one of the sources of discrepancy between those two aspects. So curious on both sides of the model.
You can get another one, right?
Yeah.
Yeah. Any other question? Because I saw a hand from the other side. Yeah, please.
So my question has to do with the many points of potential intervention that you raise here. And especially on the demand side, it gets to the question that was raised where demand is a function of perceived need. So the perception of need may actually be out of whack with what might be ideal from the sense of how many physicians per 1,000 people do you really need, as opposed to, say, how many nurses or other healthcare professionals. So my question is, on the demand side, is there any evidence at all that one can change the agenda for demand to, in a sense, deflect the demand curve in a specific direction that you feel you should go? And I guess that would involve policymakers and make an assumption that they even know what direction the demand curve should be shaped.
Can get another one because it's very simple. Nope. Okay, thanks for the question. I think give some more time to go back to some of the stuff I said. And first thing is for the scenario for the millennials, I think this paper has been distributed, I believe, Patricia, right? With the package. It's basically some different scenarios of demand and supply. If I'm not wrong, if I recall well, the millennials is because they tend to have different preferences in terms of working hours, for example, right? So in that, of course, influences the supply of health workers. Because if they're going to work less hours in terms of full-time equivalent, you're going to have a different supply. I think the question about the needs and demand, I think in that sense, as far as I understood, is very similar. As I said, this is a challenge in let's forget for 1 second health professional education, but it's a challenge for economists working in the healthcare, right? Because, as I said, first of all, information gaps. I'm talking first about the individual level, right? For information gaps, as a patient, I don't know what I need, right? And of course, I tend to go for some signals, right? Sometimes, if this place is clean, if the health professional is friendly. Some few years ago, when I was a grad student, I look at what drives demand for private health insurance in Brazil. And one of the things that people decide to buy private health insurance, given that everybody's covered by the public sector, it's a universal health coverage, it's a universal system, is because it's staff friendly. It's because of the cleanness of the healthcare providers, right? So there are some quality signals that are completely unrelated to my health needs or population health needs that influence the actual demand for care. So basically, people, they are already insured, but they go and buy a second insurance because of these signals. if the doctor asks the name of the patient, right? If the place you go is clean or not. I'm saying that to illustrate to say the drivers of demand is most of the time completed, not completely, I'm exaggerating, but completely, not completely, as you said, no, is often not related to the actual need, right, from the individual side. No? So this is a challenge for the economists because you say, if you decide to buy other goods and services, you just go there and buy. I know what I want, no? I need the iPhone 7. It's not 7, but I need one. Or I believe I need one. I can go there and buy. I don't need to ask anybody to do that. Of course, in healthcare, it's completely different. And as I said before, is two aspects of that. Is one that even if I go to a doctor or to a nurse, a midwife, and say, and get a prescription, get advice, I'm not necessarily going to follow that because I'm probably going to follow some other market signals, right? I'm going to Google and say what's the best medicine and go for that instead of go for the one that was being prescribed to me. And probably this one is even more expensive than the one that the doctor prescribed to me. Um, um, so this is one aspect of the individual choice, right? The needs and demand. You know? So we have the needs, the demand is not driven most of the time or very often by the needs, no? The actual health needs. But from the other side, also have the opposite, no? The supply induced demand. So if the health professionals know they know more and they have the ability to influence the demand, we can tend to, as I mentioned for China, for instance, no? There was a tendency to overprescribe, right? Because professionals want to top up their incomes. So from both sides, from an economic perspective, again, the needs are completely unrelated to not completely unrelated, is unrelated to the need, or the demand is unrelated to needs, right? So, and then, I mean, this gives us the issue we were talking before, no, about the cost, right? So this drives the cost because people are making choices that are not necessarily the best choice, right? And of course, in healthcare, we have the consequences are critical, right? Important to look in the policy perspective. You can locate resources to buy phones, cars in a wrong way, but of course not in the healthcare. So this is individual perspective, but if you look at the aggregate labor market demand curve, you know, so that's another challenge because what we see, for instance, is some proposal, like WHO 2006 proposed 2.3 doctors, nurses, midwives as the ideal combination, as the minimal standard to provide 8% of coverage of some service. But then you go to Nigeria and you see in a health center in Nigeria, in rural areas, one physician sees one patient a day. So, I mean, the need is not necessarily, this 2.3 is not necessarily follows the best allocation of results in terms of efficiency, right? So now the WHO comes up with this 4.5 per thousand, no? And again, is it the best demand curve? Is the best shape of demand curve? I mean, we need to look at the efficient aspect of that, right? And it probably is the shape of the demand curve varies very much population to count, right? Demographic, epidemiologic profile, and even more, varies very much on the finance side. No? I hope I show here the interlink between finance and the supply side. And probably if you look at the counts, for instance, in the US, you see the composition of the workforce here is completely different the composition of the workforce in I don't know, Guinea-Bissau or in Brazil or in South Africa, because there are a lot of factors that is related to the finance that influence the shape of the demand curve. What we need to do, I think one of the recommendations here is to see what's the shape that maximizes the investment, right? Sorry, I talked too much.
No, it's great. No, it's great. Thank you so much.
I think there was a follow-up question. The gentleman was very
We just need to.
anxious.
I hate to say this as a non-economist, but it seems to me that once you get into the fact that there's supply-induced demand, that you pretty much have to conclude that classical economics is not terribly useful here. And while I recognize that there have been major problems with, let's say, government planning or policymaker planning of healthcare workforces, that in fact it seems like a reasonable argument when you combine all of these things for trying to determine what the real needs are, figure out how you might meet them with what may not be the current configuration of healthcare workforce, and then do what I think was possibly being suggested here, which is to market the right kind of workforce to the population. Years ago, when I was in an HMO where we started our own, a classical one, a staff model HMO, not the things that are called HMOs, we started our own nurse practitioner training program because they just didn't exist, and we became the largest employer of nurse practitioners in the Northeast. But in fact, there were limits to the degree to which we could use the model of having teams of physicians and nurse practitioners, because it was so different from the overall marketplace. And we really had to market the fact that we were using nurse practitioners, that there were data to show that their care was equivalent to mine. Perish the thought, but it was true. And so, in fact, I think and we did it to a certain degree of success, and I think that that's a direction that needs to be thought about.
Just a quick comment. I have no arguments already. We are over time. I mean, I say it's probably the economic is good in the way that we see what's the drivers, right? I mean, we're not using economics to say that that's using market is good. I think it's the other way around, no? To say, look, if you look from the economic perspective, those are the market forces, and those are what we need to do to correct those. Because if you think about this, and if you see the allocation of results, how the choice people are making, even the cost of education. If you look on economic perspective, the market is working well. People are making the choice because they have high returns. The cost is going up because we have excess of demand for training. But then the question for us is to say, again, back to an economist's view, is to say, are these outcomes what we need? And then I completely agree with you to say, look, we need to guide the allocation to what they have the highest impact from a social perspective, right? And one last comment is, one way could be you just raise the compensation for those people that we are more interested in the student to go, right? So why family medicine and general practice, they have so much lower compensation than cardiologists and other high skill occupation, right? So I think the look from an economic perspective is to see those are how the market is working. But if you change some of the parameters, we can change the outcome, right?
Exactly.
Thanks again.
Thank you so much, Edson.
Thank you
very much. So this is exactly what we hope to do, is spur conversation, get people involved. And so what we did, a few of us, Zure and Rob Smith, based on the amazing information that Edson pulled together, we thought it would be useful for this committee to have a sort of living, breathing model to work from in terms of developing throughout the day our idea of how we're going to create these levers that are going to shift health professions education financing in the direction that we want to go. So just to review, Edson's talked very eloquently about population health needs. On the one side, really, what does the population need? And on the other, what is the health professions education system producing, given their incentive structure? And then mediated in between by the market, the labor signals that we're saying sometimes work, sometimes don't. There's some market failures there. But basically, this is the fundamental model. And then we wanted to sort of turn your attention, as I mentioned, and it's in your one-pager, to what we thought we would pull together in terms of the guiding principles. So what if we were to design a health professions education financing system? Would it look like in an ideal world, right? It would be responsive to society. It would reflect need and not just demand that's manifest in the market. It would be transparent. We haven't talked a bit about that this morning yet. But this whole question of, do we know what we're paying for? So it's 2%. I understand that really powerful point this morning. But Edson's second point was, it may be a small investment, but perhaps we're not utilizing it the best way that we can. So would transparency, knowing how we're spending those dollars, knowing what we're getting for those dollars, increase the effectiveness of that investment? We also need it to be nimble. Clearly, we don't know fully where this health system is going to end up, right? In any of our countries. We need to have a system that's able to read not only market signals, but look ahead to be able to figure out where will the market be, right? Because it's not good enough to read the market signals today when you're trying to train a profession that has a pipeline that's 5 to 7 to 9 years out, right? So let's keep in our minds the fact that we need to be sort of thinking ahead and make sure that our system is nimble. And then it has to generate value. It has to generate value to multiple actors, right? To the government that invests in it, to the individual who invests their time and money, to the education system, to the healthcare system. So it has to generate that value. And then it has to be lifelong. We can't just think that we're going to fix the healthcare system by investing in the pipeline, because we're going to wait a very long time for people to come out who have those new skills. So we're going to have to invest in that lifelong learning. And it's going to have to be ethical. This is something I've talked to a number of you about, is if the market is sending signals that are incorrect and students are taking on a huge amount of debt and they get out and there's no job, that is not where we want to be at all, right? So we need to be thinking about the fact that debt load is a huge issue in students having opportunities, and that it really does need to be interconnected. We need a system where we have the connection between practice and education. And I know this is sort of the, this is your wheelhouse, folks. This is where you are. So we need it to be responsive and connected. So, but we're looking to you today to add to this list. What's missing? What did we not come together and have? So this is where we're going to go today. So unpacking these boxes as Edson did, this is the model sort of that says on the population side, we have the burden of disease, which is pretty focused, folks, traditionally in many countries, particularly in the United States, on curative needs, right? And we are not fully focused. We have weak demand. I liked that phrase, weak demand from those rural, remote, underserved, poor populations. And if that demand is not manifesting itself, as Edson explained, we're not responding to it on the one side. On the other side, we have the health professions education and training system that is influenced by models of training, by policy, by licensure, by regulation, by faculty. We may know that we need to have more nursing education, but we may not have doctorally trained nurses. We may need more social workers who understand the healthcare system, but we may not have the ability to find those faculty. So faculty issues and constraints are an issue. And then students' ability to pay. And all of those, as Edson so eloquently outlined, create these market signals that go to the individual to influence their career choice in terms of the return on investment. So this is where we want to spend our time today, is in the mismatches. So where are these mismatches between population health needs and what's demanded, right? We have this mismatch between the fact that we have weak demand for some of these underserved populations. We have expensive care in a fee-for-service model that is very focused on curative. We're not as focused on prevention and primary care and the social determinants of health. We know that. So there's one mismatch, right? We have the mismatch between supply and demand that is resulting in the fact that we don't often, and I'm a workforce modeler, so I can say this with great humility, we don't get it right. And so we create a place where we say, we're going to need more of X profession, and they gear up and they start producing them, and then we get it wrong, and people don't have jobs, or they're underemployed. Or we don't predict demand, and we have excess demand. And so we sort of, I call it lurching from oversupply to shortage. And so we have this imbalance here in the middle that we're going to need to address. And then between supply and health professions education, we end up with a mismatch between what is being produced by a system where the individual is making a choice and the system is producing it, and what the population needs. And we do have students who come out with large debts. And so we have these skill gaps that exist. And especially, I want to highlight the skill gaps as the system's transforming so quickly. So how do we gear up for care coordination, patient engagement, population health, informatics, interprofessional? So we're asking the system to be nimble and move quickly, and that's hard to do. So there's a mismatch there. So I know we're close to time, so I'm going to look over to Patricia and say, we have 2 more slides for the model. Do you want me to go through the slides, or should we engage now on each of the mismatches? Could we see if anyone has any comments or wants to add anything to either the part that we just reviewed, or whether they have questions about this mismatch? Because this is going to be our living, breathing document that we're going to go back to during the day. So are there any comments thus far?
No, I think these are really important issues, but I think it's also who gets educated and who is in the faculty, and that reflects both,
Nice.
you know, what gets taught. So I think it's important to think of the kind of, and that was mentioned, the models of education that are not meeting needs, but it's also who's in there. And another thing which I think is important is in terms of demand, is that many underserved populations do not have a voice and don't know that they can demand. So I think that, you know, there's a lot of spaces that need to be worked on, and that's why it's so much bigger than just education.
Thank you. Exactly. To that last point is Edson's point about information costs. Are there any other comments, questions? I'm going to go to Malcolm and then the back of the room and then over here.
In the previous session, it seems to me what bedevils this whole thing is the difference between real needs and perceived needs and how one defines those. And so I would hope today we get into that, because that distorts this population health need definition. I mean,
Right.
are you talking about real needs and who decides
What a
what's
need.
real and perceived? Because without some clarity around that, it seems to me that you can't get into the other mismatches. I mean, I'm not at all convinced, for example, that we know what we want when we want to buy a smartphone. They're heavily marketed. We buy stuff we don't need. We buy stuff we don't even know we're paying for. And so it's really this, it's a more broad economic mismatch or lack of real versus perceived things. Now, to what degree that's even bigger in the healthcare market, I don't know. I mean, I'm not an expert. But so it seems to me it's both a generic phenomenon and a real problem with how we analyze these.
Comment, there was a comment back here somewhere.
Just another element I'm not sure I've heard represented, and that is the economics of the health professions training programs in terms of starting up new programs that appear to be lucrative and maybe an oversupply on our end. And so it's the academic economic model that I think really influences the supply piece as well. Also, the resources that are made available to train the health professionals that are in these programs, and how the economic model for higher education contributes to what we can do in that regard.
Right. Thank you. And then there was a comment over here. Yes.
Two comments. One, and I think it's reflective of the current model that we have when you say expensive care versus prevention. I think it's health, well-being, and prevention, because prevention is really targeted toward a disease model still, and that's not where a lot of populations are. The second one, which was really kind of related to the comment before, I don't know that you have dressed up there the issues of the duplication that we have within the health education system that causes it to be so darned expensive.
Okay. Thank you. And there was a comment next to you as well, I think.
Yeah, I want to first support what Patricia said. It's the framing that Don Berwick has used, that we need to move towards a system of health creation, which moves well beyond our usual, you know, when he's talking about the 30-year move towards health creation, that's way beyond what we think of as prevention.
Right.
I think also just for framing the whole concept of moving from a focus on production in our medical delivery, which is, you know, this is the conversation that's going on big time in AHA, to one that's focused on values in a context of knowing that 1/3 of what we do is waste. So what is that in terms of supply? So as we grapple with waste and figure out the supply that's related to waste, how does that factor in here?
So we're going to go quickly through the next few slides that we want to talk about. So basically this is perfect because it's setting up the fact that as we're thinking about the system that doesn't align, what are the drivers, right? The drivers in the training environment we need to be thinking about. We need to be thinking about healthcare coverage, right? So how does need manifest itself as demand? The accreditation, licensure, and certification requirements that drive a lot of what gets produced in the health professions education system. Edson mentioned employment opportunities, how the market actually provides a signal that we need a job there. The whole issue of financial support for education and training, the demands from payers those payers are the taxpayer, the students, the foundations, and other. And you mentioned this issue of adequately trained faculty, and do we have the people we need, and student debt. So these are some of the drivers that we want to think about, but we're looking to you today, just as you have in the last slide, to identify what drivers we are missing, because we also want to get to looking at the levers, right? So these are, how are we going to address this? What kinds of financial support do we need for education and training? How do we need to influence the broader policies in our countries around financing health professions, education, training? How do we create these financial these efficiencies, right? So if we think there's waste in that 2%, how do we get some efficiencies out of it? And how do we control for the market? Or maybe, to Dr. Schoenbach's point, maybe it's an issue of trying to balance, the market planning with the market, right? So we're going to have something between social planning and the market, and where do we find out, where that space is, and how do we create those incentives? So those are some of the things that we want to think about today and throughout the day. So we're asking you to keep this model central in your minds, add to it, scribble on it. It's living, it's dynamic. But I'm going to turn it over to my co-chair now, right? So we're doing table. Okay, we're actually taking a break. Perfect. Okay, excellent. Well, thank you very much. It's been a great morning. Return at 20 after, please.